Good morning, everyone. Here for the August 20th, 2020 press briefing from Bryan Health. I'm Bob Ravenscroft, Vice President for Advancement. We have a great special guest with us today. Proud, hometown kid from Hastings, Nebraska, graduate of the University of Nebraska Medical Center in Medical Laboratory Science. We have Jayne Ellenwood. Jayne is our clinical laboratory specialist for point-of-care testing, and she's going to share a little bit about the differences between molecular, antibody, and antigen testing. I did have an advanced question on, are we skewing younger on our counts now that, things are getting back with school? Just got this information literally as I walked in. I'll address that after Jayne's presentation. I need time to actually digest the spreadsheet that was sent to me here so I can get you what you asked for, Brent. Real quickly, our lab testing supplies, not much has changed since Tuesday. The Cepheid test is still in what we consider a critical status. We have 6 days on hand. Of course, we expect our next weekly allocation to bolster that, hopefully. Our Aries test is still at the cautionary level. We have 17 days on hand. And then for swabs, media, and so forth, that is the basis for what we send out to LabCorp. We have sufficient supply. Our midnight census was 475 patients. We have now tested 19,737 patients here at Bryan, resulting in 2,243 positives, and we do have 115 pending. Right now, we have 8 COVID positive patients in the hospital. 3 are from Lancaster County. We have 2 additional patients, one from Lancaster and one from outside, that are inpatients but pending their test results. And we only have 1 patient currently on a ventilator. As for drive-through, it did dip a little bit. We got as low as into the 40s, and then yesterday that climbed back up into the high 70s, and I don't know what the count is for today. So a little up and down on that, but that's where we're at right now. So with that, I'm going to invite Jayne to come on up. She's going to share the information on testing, and then, again, Brent, I'll digest this data and see if I can get you an answer before the end of the press conference. Jayne, it's all yours.
Hello, my name is Jayne Ellenwood, and I am a clinical laboratory specialist here at Bryan Medical Center. I oversee point-of-care testing at the medical center, and I am here today to talk about a new rapid COVID antigen detection test that myself and my laboratory team have been working hard to implement here at the medical center. To start out with the test, we are going to be implementing this in our emergency department to assist in our screening tools for patients who present to the emergency department, as well as help to reduce certain wait times that certain patients have while waiting for coronavirus testing at the medical center. Next, I would also like to talk to you about testing differences, including molecular testing, antibody testing, and this new rapid antigen testing, as it can be confusing when your world is not all things laboratory and coronavirus testing. So molecular testing, also referred to often as PCR testing, detects the virus's genetic material. The sample type of collection here at the medical center that we use is a nasopharyngeal swab, which, as you may have seen, is inserted deep into the nasopharyngeal cavity for collection. This test is used to diagnose active coronavirus infection in our symptomatic patients. The next type of test is antibody testing. Antibody tests detect just that, antibodies, and antibodies are Y-shaped molecules that your body has created in an immune response due to a past COVID infection. The sample collection type for this test is a blood collection where your serum is tested for the presence of antibodies. Antibody tests are not used to diagnose active COVID infection. Antibody tests indicate a past infection. The next type of test are rapid antigen tests, which is what I'm here to demonstrate today. Antigen tests detect specific antigens on the surface of the coronavirus that are present in the acute phase of the infection, which have shown to be about a 5 to 7 day window of the symptom onset for patients. An added patient benefit to this test is that the swab collection is a nasal swab collection where the swab is inserted about an inch into the nasal cavity. And antigen testing is used to diagnose active coronavirus infection. So now that we've covered the different types of tests, I did bring some components of my kit test to just show you what it looks like and just give a very simplified testing process. All right, so the kit comes with a nasal swab and an extraction reagent tube. We have a test cartridge, and then the test cartridge is read on a reader, which ensures that the naked eye does not miss what the cartridge has truly detected during the testing process. So our testing process starts in the collecting department with a dual NAIRS swab collection. The test is then sent down to the laboratory where medical laboratory scientists start to process the specimen. They take the swab and insert it into our extraction reagent tube. They agitate the swab for 15 seconds. Once that process is done, they take the test cartridge and they add 3 drops of the processed specimen into the sample well of the cartridge. Once that process is complete, they let the cartridge rest for 15 minutes. So that is the 15-minute rapid turnaround time that we have for this test. Once that test window is complete, our scientists insert the test cartridge into the reader. It takes about 3 seconds to read the test result. And then the reader displays as to whether or not the patient's specimen was positive or negative for the SARS-CoV-2 antigen. So it's a very simple, quick process that I'm really excited to be rolling out here in the medical center. And thank you for having me today.
Positive test here at Bryan, between the ages of 10 and 19, they account for about 10.7% overall since the inception of our positive results. For individuals 20 to 29, overall, they represent about 24% of our positive results. In August, in that 10 to 29 category, it did jump to account for almost 16% of our positives in August. And then from 20 to 29, it actually dropped in August, where about, again, 15.91% came from that category. The high water mark for individuals 20 to 29 was in the month of July, when they accounted for 38% of our test. I think your question was also getting towards school going back in session. So if we drop down another age bracket for patients 0 to 9 years of age, overall they have accounted for 3% of our positives. In August, that was 4.55. Numbers are small there, so I'm not sure it really tells us much. So maybe a little bit of uptick in the 10 to 29. Well, not a little bit. It's indisputable. It jumped up in August. And then a little bit of a drop in those 20 to 29 years of age.
So this will not just be a supplement, it's going to be a tool in our screening resources in working towards preserving PPE and identifying COVID positive patients as rapidly as we can using this rapid antigen detection test in our emergency department. The rapid antigen 15-minute test that I demonstrated today will be used in the initial screening process in a patient that is presented within the first 5 days of their symptom onset. If the test is positive, we will not move on to our Cepheid test, which is the molecular test. If the patient's test is negative for the rapid antigen detection, the provider will determine whether or not they want to send for the molecular version, the Cepheid, in our microbiology department to confirm the negative result if they are still highly suspicious that the patient is COVID positive. The molecular test detects the genetic material of the virus and is not dependent on what phase of the illness the patient is in. The antigen tests will be used should be used to the provider's discretion at the beginning of the patient's illness. This test will help us preserve where we're most critical with our Cepheid molecular testing and help us to identify those patients that do not need the molecular testing because they were positive with the antigen test. The antigen test also just helps with the supply chain and where if patients aren't highly suspicious of COVID antigen and they test negative, that they feel they can remove those patients from isolation precautions. When this test was granted emergency use authorization for the rapid antigen detection test, we ordered a bulk supply of tests, and we have a good supply of testing currently. They are both the antigen test and the Cepheid test are on manual allocation, but currently we are sitting better with test supply for the antigen test rather than the Cepheid test. We are going live with the test next week in our emergency department.